Labor dystocia, what does that mean? It means a slow or stalled labor progress. The diagnosis has evolved over time. What used to be considered too slow is now not so much. So let's break down the ACOG definition. Active labor matters because ACOG defines active labor starting at 6 centimeters of dilation. Before 6 centimeters is really just considered early labor, although I'm sure that if you come in hot at 3 centimeters, feeling like things are really ramping up and very, very strong, and you hear that number 3 centimeters, and then someone tries to tell you you're not in active labor, even though you have 3 to 4 minute apart waves that are lasting a minute and super duper strong, I know that that can be disheartening to hear those words, that that's not active labor. But for the purpose of whether or not you're having a labor dystocia, it's really important. So again, active labor starts at 6 centimeters. At 6 centimeters or more dilation, with what they call ruptured membranes or your water's released, and no cervical change for more than 4 hours with adequate contractions, or no cervical change for more than 6 hours with inadequate contractions despite augmentation. So what does adequate contractions mean? That means that they are close enough together and strong enough that they should be making cervical change. If someone is not sure if their waves are strong enough, their contractions are strong enough, and they're wondering, like the provider's like, okay, do we need to augment labor, or we've been augmenting labor, so we've been adding Pitocin, we're still not seeing cervical change, should we add more Pitocin? Sometimes they do what's called an intrauterine pressure catheter, or IUPC. You do have to have waters released to do that. They will put this catheter up and it goes inside of your uterus with the baby, and the squeeze of the contraction shows that thing how much pressure that is, and it's in Montevideo units, MVUs. You don't need to know that, but you have to have a certain amount of MVUs within 10 minutes for them to be considered adequate contractions. So if they do that and they see, okay, we're not having adequate contractions, even though we've been adding augmentation and there's been no change for 6 hours, okay, then that sounds like something is up, right? And then if there's no cervical change for more than 4 hours, but we do see on that IUPC that these are adequate contractions, then yeah, what is up? So when I say no change, we need to really be serious here about what no change means. Progress is not just dilation. It's dilation, effacement, and station. Any of those things changing can be considered change. What are those things? So dilation, most of us know that one. That's how open the cervix is. It goes from all the way closed to all the way open. It's measured in centimeters, so 0 to 10 centimeters. Effacement is the thinning or shortening of the cervix. So it goes from thick to thin, and that is in percentages. So you're 0 to 100% thinned or effaced. And this is especially important in early labor. A lot of that happens in earlier labor. And then we have station. So this is how high or low the baby is in the pelvis, whether or not the baby is engaged into the pelvis. All three of these things make change. If your provider checks you and they say you're 4 centimeters, and then 3 hours later they check you and they say you've had no change, on each exam you can ask effacement and station as well. So then next time, ask what effacement and station are, because that will help you see, did I really have no change, or is it just that my dilation didn't change, but maybe the baby has moved down in the pelvis, or maybe I've effaced more. So that's really important. Many people are told that they're not progressing when they actually are, and I hate to say that, but it is true. If dilation stays the same and anything else is still changing, I still call that progress. Why people get diagnosed too early. They're applying active management standards too early. They're saying this is failure to progress, or, oh, we have a labor dystocia, but at 4 centimeters, really that shouldn't be able to be a diagnosis. There are time limits that don't reflect updated guidelines and a lack of understanding of full cervical change. And a lot of times that lack of understanding is by the patient or the person giving birth. I hate the word patient, because they weren't given all of the information. They don't really understand, and they just trust what their provider says. And I wish that we could all do that, but unfortunately it's not always given to us in the most honest way. A cascade of interventions can happen, which sometimes interventions are needed, and that's fine, but it does increase the likelihood of cesarean when we need to augment or induce labor. Inducing is starting from nothing, no contractions, no water is released at all, and adding medication or mechanical dilation. And then augmentation is adding those things when there's already been waters released or some waves have begun. So what are some of the causes of a labor dystocia? There are what's called the 3 Ps. The first P is power, which is the contractions, whether or not they're weak, irregular, or maybe overly intense without coordination. And then there's the passenger as the second P, which is the baby. So what is their position? Are they posterior? Are they asynclitic, which means their head is in there a little bit wonky? Size is less commonly an issue than positioning. A big baby that's in a great position doesn't cause as much issue as a smaller baby in a poor position. And then the third P is passage, which is the pelvis. So the shape and space dynamics. Again, often it's about positioning and not that the mom's pelvis is actually too small. But sometimes a provider will say to somebody before even checking their cervix or feeling around in their pelvis while they're in labor, they'll be like, you just have a really small pelvis, like you should just plan a cesarean. That's a red flag. That is not something that anyone can tell by being able to look at a person, because our body mechanics change while we are in labor and things shift and move out of the way. So most labor dystocia isn't actually about the body failing. It's about some of the mechanics that can be supported and sometimes are not supported by providers because the full information isn't being given. What can actually help progress labor? So position changes, upright positions, asymmetrical movements like lunges, sideline releases, hands and knees positioning. I always say try to make your belly a hammock for your baby. Baby positioning techniques, that would be one of them, making a hammock of your belly. But spinning babies has a lot of movements that can be done in labor that are really helpful and encourage rotation and descent. So we got to get the baby out of the pelvis for a second to be able to let them re-enter in a better way, and doing some of those movements can be helpful. Also, our environment and our nervous system. Are you feeling like calm and safe and reduced stress and adrenaline? Are you feeling like you're watched, a watch pot doesn't boil kind of thing, and really pressured to keep going and that things aren't dilating and moving along quickly enough? We really need to support that oxytocin flow. The hormones of labor are really, really important. And that adrenaline blocks oxytocin, which oxytocin is the producer of those contractions. So if we have adrenaline, which is our stressor hormone, kicking in and blocking oxytocin, then of course our waves are going to space out. Of course we're going to be, a labor dystocia. And then we have emotional support. Fear and tension and stress can impact labor. So making sure that you have somebody around you that you feel safe with, continuous support from a partner and or doula. Some medical options to help move things along that sometimes do work. Amniotomy, which is breaking the waters. I don't love this one, but it can be helpful. Be careful about when you consent to this though, and it should be done with knowing those brains questions and answers. What are the benefits, risks, negatives? What does your intuition tell you? What if you do nothing? And then asking for space to decide. So if your waters are released for you, that also, if a baby's already in a poor position, it's really not great to have your waters released, because then that baby has a harder time repositioning. Pitocin augmentation can create that stronger contraction to help move the baby a little bit, which can be helpful. And then an epidural can sometimes help, sometimes hinder, depending on the context. It's like one of those commercials where at the end of the commercial, when they say the medication, they're like, this can cause, and it says all opposite effects like diarrhea and constipation. You're like, how can it do both? So I know hindering or helping isn't maybe a helpful thing to hear, but an epidural can be helpful. So there's a time and a place for medical support, but it should be used from an accurate diagnosis.